Hello, everybody. Hopefully you can see me. Thank you very much for the invitation. I'm going to get straight into it. So I'm going to talk a bit about the science of childhood adversity, trauma, and resilience, and how we can think about this in the context of moving towards a trauma-informed system, as Hazel's just alluded. So I want to start by saying we have a real challenge on our hands. We've got a massively increasing level of demand for services. We've got a depleted workforce, both in terms of number and resilience. People are doing two people's jobs quite often. So the vacancy factors in the NHS and social care are, you know, I think there's 160,000 vacancies in social care and about 155,000 vacancies in the NHS, just by way of example. And that kind of trend has been going on for about 10 years. So we have to do something to kind of reduce that demand. And part of that is going to be about investing in prevention. There are a lot of preventative interventions and programs that we know have a lot of evidence. And we really do have to think more about how do we meet people's needs and help them stay well? How do we kind of move upstream? How do we do this early intervention better? And at the same time as that, as well as looking after the workforce, as well as improving the numbers in the workforce, we also have to kind of implement this trauma science, this theory of trauma and resilience into our services, both in terms of benefiting the workforce, but also in terms of benefiting the service users that need help. So that's the challenge we've got on our hands. It's not a small and insignificant task. It's quite a lot to think about. But I like this quote from Desmond Tutu. It sums things up really. There comes a point where we have to just stop pulling people out of the river. We have to go upstream and find out why they're falling in. So I think that says it all. And I like to use that at the beginning because it frames everything else that I'm going to talk about. We can't just keep picking up pieces and expect that to be a solution. So this is a talk about stress. So, people talk about trauma, and really, I think often forget that what trauma is a kind of injurious stress. Stress in and of itself is a term that wasn't really applied to humans before the 1970s. Hans Selye wrote a book in 1978. He researched the stress response in animals and humans, and he came up with that term, the stress response. He was nominated for 17 Nobel Prizes, but I don't think ever won one. But he's responsible for our understanding to a large extent of how stress affects the body and the mind. Gabor Mate more recently said, stress is a biological process which results in a wide range of events in the body, which occur when the organism perceives threat to its existence or well-being. This term was borrowed from engineering. Stress was officially an engineering term which referred to the effects of force acting against resistance. So when we think about that, we can appreciate that some kinds of stress might be tolerable and healthy, and some kinds of stress might be injurious, traumatic, or toxic. And that happens when the demands made on the organism exceed its capacity to cope with them. The word trauma means injury or wound. It comes from the Greek language. So we have to kind of bear in mind that we're talking about the kind of stress that leads to an injury or wound. The American Psychiatric Association, they define it like this. They talk about there being a terrible event, and then they talk about the classic post-traumatic symptoms: intrusions, intrusive memories and mental events, high levels of avoidance, high levels of physiological arousal, mood disturbances. And they rightly point out that most people move on, actually. So about 70% of people move on and recover naturally after those initial symptoms, following a single potentially traumatic event. About 30% of people won't move on, and they'll have more persistent problems and probably need to get some sort of professional help. SAMHSA, the Substance Abuse and Mental Health Services Administration of America, they describe a slightly more comprehensive, broader perspective on trauma. They say it's an event, series of events or set of circumstances that they're experienced by that person, perceived by that person to be physically or emotionally harmful or life-threatening, and that the event has lasting adverse effects on the individual's functioning, whether that be mental, physical, social, emotional, or spiritual. And I think that is really important. We're talking about lasting adverse effects. People use this term traumatic in everyday language, like, I was stuck on the motorway for 2 hours, it was so traumatic. And I always say to people, did it leave lasting adverse effects on your mental health, your physical health, your relationships, your emotional well-being, your spiritual well-being? And if people say, well, no, but it was really frustrating, then I go, well, it was frustrating and annoying, but it wasn't traumatic. It didn't cause an injury to your mind or body. And then we develop this idea a little bit further, and we look at Bessel van der Kolk's statement. This was from a letter to the New York Times, actually. He said traumatization, i.e. the harm that occurs, this injury, happens when your internal or external resources are inadequate to cope with the external threat. So, in other words, and I put this picture of the balancing scales up here, trauma, stress, adversity, loss, and tragedy land on this side of the scales. And on this side of the scales, we've got resilience, coping strategies, well-being, resources, assets, ways of adapting. And those things counterbalance the stress, the traumatic stress that lands on this side of the scales. If there's enough on this side, it can mitigate the impact of things landing on this side of the scales. But sometimes things land on this side that are so huge and overwhelming that the scales will tip. And then the challenge is, how do we get the scales to come back into balance, this position of balance, homeostasis, as Hans Selye called it? How do we get back there? Well, I think there are two ways of getting back to balance. One is we lighten the load here. We deal with some of the trauma. We process it, we contextualize it, we take some emotional pain away from it. Often that's done through talking, through writing, through psychological therapies, EMDR, CBT, trauma-focused CBT, CBT for psychosis. The other way of doing it is, because this isn't available to everybody, it should be, but it isn't. The other side of the scales is where a lot of people spend most of their time, which is building those coping strategies, building those resilience assets, finding ways of adapting. Social support is one of the best forms of healing, actually, for trauma. So people have to work on these scales. And as professionals, we have to kind of work out, where are we focusing our efforts? Is it on both sides, or is it just on this side? Excuse me. There are many different kinds of trauma. There's an endless list, potentially traumatic events. But they seem to fall into a category of abuse, physical, sexual, emotional, domestic, occupational, loss experiences, death, abandonment, neglect, separation, acts of omission, man-made events, natural occurring events. And then I think the category we forget about, actually, is the chronic stressors like poverty and racism. We know that, for example, that poverty has about the same impact on immune health and longevity as smoking. It accounts for about 14% of premature death. Humans are not designed to be existing in isolation. We're pro-social creatures. So poverty is really a kind of insidious form of stress that chips away at someone's resilience. Excuse me. So, in terms of how common these experiences are, 70% of people around the world in this World Health Organization funded study, 69,000 people, 26 countries. They were given a list of 29 events matching the criteria in DSM-5, which is the psychiatric manual of the American Psychiatric Association. And on average, 70% of people around the world in these countries said they've had at least one stressful experience that met the criteria for post-traumatic stress in that manual. 30% of people said they had 4 or more experiences. And the interesting thing about this in this study was they found that the most common protective factor that predicted recovery or people staying well after this potentially traumatic event was close social support. And this is a finding that comes up time and time again. Social support is a crucial factor for recovery. There's another kind of trauma, which is often referred to as toxic stress, which is the adverse childhood experiences. I refer to them as developmental trauma because these things happen while children are growing up. And this list of 10 categories of childhood trauma are all things that have been studied most extensively. And obviously the list is not, it's not exhaustive, but these 10 categories are the things that we have the most research around. There have been about, I think 40 plus studies now at a population level since the original study, which was in 1998 by Vincent Fleety and Robert Ander. The interesting thing is, since that original study, the 40-odd studies that have gone after that all find similar results. So the original one was pretty groundbreaking in that it revealed that adverse childhood experiences were incredibly common, even in the population they studied, which was white middle-class Americans in San Diego who could afford health insurance. 64% of those people said they had one adversity growing up, and a quarter of people said they had 2 or more. So it was pretty shocking. What they found was there was a dose-response relationship between the number of ACEs that people experienced growing up and their health outcomes. So in that original study, they found this dose-response relationship. Bigger the dose of adversity, worse risks of poor health and worse incidence of poor health, physical health, mental health, and social problems later on. So that pattern, that dose response pattern, has been observed for the past 25 years at population studies. So it's a very robust finding. In England and Wales, we've had our own ACE surveys, and roughly half the people in England and Wales said they've had at least one ACE growing up, and 1 in 10 people have had 4 or more. Overall, people with more adversity compared with people who have had none tend to have more chronic diseases in adult life, higher incidence of cancer, heart disease, inflammatory conditions, mental health issues, more likely to be involved in violence either as a victim or as a perpetrator, use more health resources, tend to do worse in education, use more emergency services, more often involved in the criminal justice system. The list goes on. What I should say is, at an individual level, you might have resilience factors that counterbalance these adversities. So if you've got enough resilience factors, you could have 4 or more adversities and still be perfectly fine. But at a population level, this pattern, this dose response pattern, is very stable. What's predictable is preventable. So that's also kind of good news from a public health angle. But even though we know this is responsible for a lot of the health outcomes we're struggling and the social outcomes we're struggling with in society, it's rarely asked about in routine practice. Professionals rarely ask directly and explicitly about adverse childhood experiences as part of their assessment. I'm going to touch a little bit more on that shortly. The English ACE study from 2014 found that people with 4 ACEs were more likely to engage in behaviours that harm their health. So, for example, people with 4 ACEs were 7 times more likely to have been involved in violence in the last year. So a 700% increase in risk. People with 4 ACEs, compared with those who had none, had 11 times more likelihood of using crack or heroin and going to prison. So 1,100% increased risk. In addition, we look at the best meta-analyses of studies that look at the relationship between childhood trauma and mental health outcomes, and we see again a dose-response relationship. Bigger the exposure to childhood adversity, higher the risk of developing any of these mental health problems. I've crossed the word disorder out because I don't think it's necessary or helpful, but all of these things have got evidence that says more exposure to childhood trauma, greater the risk of developing these problems. In some cases, we know we can prove a causal relationship, like in psychosis. Physical health problems, I think we're less, it's less intuitive to think of physical health problems occurring as a result of childhood adversity, but there's a huge amount of evidence. The science is called psychoneuroimmunology, and we see that stress affects every system in our body. People with 4 adversities in Wales in this study of 2,000 people from 2018 were more frequent attenders of the GP, spent more time in hospital, had more overnight stays in hospital, went to A&E more often. They were also 4 times more likely to develop type 2 diabetes and 3 times more likely to develop heart disease and respiratory disease, all of which are generally a combination of lifestyle and inflammation, stress-related mechanisms. So often these things are treated medically and seen as a medical complaint, a pathology, but actually stress plays a really important part in this whole story. Hans Selye talks about this in his work. Every stress leaves an indelible scar. The organism pays for its survival after a stressful situation by becoming a little older. And more recently, the American Pediatric Association have been publishing some really interesting stuff, and they're training their doctors now to have a much better understanding of psychoneuroimmunology. But in summary, they say chronic dysregulation of the neuroendocrine immune system via the HPA axis, which is the hypothalamic pituitary adrenal axis, your stress apparatus, has been documented to compromise nervous, immune, cardiovascular, reproductive, and endocrine systems. The bottom line is the stress response, a chronic high level of stress, the fight or flight response being triggered repeatedly. Maybe you're living in a harmful, dangerous, threatening situation. Maybe you're growing up in an environment like that. Your stress response is going to take its toll on your body. It's going to wear out your main systems like your immune system, and it's going to cause premature wear and tear. And we're starting to understand that now. we can look at the economic cost. So in England and Wales, this paper came out in 2020. It was really interesting. Just came out just before Norman Lamb and I went on BBC News to talk about the psychological and social consequences of COVID that we didn't think the government were planning for at the time. And lo and behold, we see huge amounts of consequence and demand resulting from that period of COVID, which I won't get into. But the bottom line is £42.8 billion every year is the cost of meeting the health burden of conditions caused by adverse childhood experiences. Most of this cost is a result of mental health problems, diabetes type 2, heart disease, respiratory conditions, and inflammatory conditions. So if we were to take a tiny percentage of that £42 billion every year and invest it in prevention, we'd probably see a massive return on that investment. So economically and humanitarian terms, we have to do something different. We have to get upstream on all of this. A lot of what we do actually is we treat the symptoms, but we ignore the cause. This is because we're not finding out what's happened to people. Instead of asking what's happened, we say, what's wrong with them? Let's get a diagnosis. But it tends not to work. It's a sticking plaster. Let's take, for example, obesity. So people often, well, these days, the treatments for obesity are multiple, but one of the treatments that is offered these days is bariatric surgery. People have their stomach reduced in size and they can eat less, and therefore they lose weight and become healthier. And on one level, that's seen as a medical success story. But on another level, when you look at long-term outcomes for treating that symptom, which is essentially people using food to feel better, it's their self-soothing mechanism. They use food, it makes them feel better for whatever reason, but there's an underlying pain. But we take away that coping strategy, so people can't use food to feel better. And we look at long-term outcomes and we see 4 times the rate of suicidal behavior and 4 times the rate of mental health issues in people who've had that surgery. You can't take away someone's coping strategy without giving them something safer and better. And unless you deal with the underlying pain, the symptoms will just keep re-emerging. It's the same with addiction to opiates, for example. The best service in the country has a 10% success rate in getting people to come off opiates altogether. Most services are not commissioned with a full therapeutic program to help people address their adverse childhood experiences. We've got to ask people why they're in pain, and we've got to understand the link between their past experience of trauma and pain and link that to their here and now, to their current difficulties and the way they're coping. And if we can help them heal their past trauma, maybe their pain will reduce and maybe they won't need to use gambling, smoking, alcohol, drugs, food, whatever it is they use to self-soothe. So maybe this is part of the solution. Trauma-informed practice is something that everyone's talking about. My image of the book by Maxine Harris and Roger Fallett from 2001, which is called Using Trauma Theory to Design Service Systems, was the first time this term was referenced. It's not appeared, but it's definitely in the slides there. SAMHSA, who we mentioned earlier, they published, after Maxine Harris and Roger Fallett's book, they were social workers working in America, in New York actually, they said, everybody we see is affected by trauma, but yet our services don't address that and we're not sensitive to that. And we're not equipped to deal with it. And then a few years later, SAMHSA published this document in 2014, which talked about trauma-informed being a program, an organization, or a system that realizes the widespread impact of trauma and understands how many different ways there are that people can recover. Also, it's about recognizing the signs and symptoms in the people around you, colleagues, friends, family, clients. And it's also about responding differently. Once you get the knowledge and the understanding, you can make different choices, respond in a different way, one-to-one. Maybe as an organization, you change your policies and procedures. Maybe you look after your workforce differently. And absolutely, we try and be aware of the opportunities where we might inadvertently re-traumatize people. So ultimately, we should, at the very least, not make it worse, which is easier said than done, actually. I often do workshops on this, and we talk about what are the ways that services re-traumatize people? And we can go on for a long time with that discussion, because there are so many ways that we do add to people's burden inadvertently. So Sam's also say there are some principles we should follow. And this is the bit that I often say, it's not rocket science, but it's quite hard to do every day. It's quite hard to do in every interaction. For both staff and service users, actually, do people feel safe? Because trauma is a kind of persistent threat. It's a kind of feeling not safe. It's about feeling unsafe, actually. It's a kind of fear that never goes away. So trying to create a sense of safety for people, both in terms of your context, your relationship, your understanding of what's going on, that's going to allow people to relax and be regulated in the nervous system. It's going to allow the prefrontal cortex to function properly. It's going to allow them to develop trust in our relationships and form a connection and learn and grow and contemplate and process what's going on. And it's just the same for staff. If they don't feel safe, they're not going to operate at their best. Psychological safety, as well as physical safety and environmental safety, is what's important. Transparency is crucial, because if we're not transparent about what's going to happen, how it's going to happen, what people can expect, it creates fear. And that makes it hard then for them to feel safe and to trust us. Samsa suggests that peer support's an important part of the recipe. And actually, some people, whilst they might need experts by qualification, they might also need contact with experts by experience. So that's an important component to consider in any program where we're trying to help people overcome trauma. Collaboration is crucial, because it's about partnership. This is about doing things with people. It's about doing things alongside people, not doing it to people, not being in control, not being the ones with power. And empowerment is a really important part of this whole story, because often people have been abused, often people have been coerced, often people have been disempowered. They've had their power removed, or they've had power used against them, or they've been disenfranchised or marginalized. So actually, if we can give people choices, if we can let people know what their rights are, give them a voice, help them choose, help them feel empowered again, that's part of the healing journey. Absolutely. And then finally, we should be sensitive, professionally curious, and professionally humble enough to say to somebody, I don't really understand much about your culture or your spiritual beliefs or your, where you grew up. And actually, maybe that'd be quite useful. What do I need to know? Because if we're not sensitive to these things, it can become a barrier at best, or at worst, we can offend someone or blunder through a situation where we make it impossible for that person to feel safe and valued and respected, and to make good use of our services. So in a very quick nutshell, they're the trauma-informed principles. Hopefully I've made the case for change here. But now I'm going to talk a little bit about how we've applied some of these ideas in the course of my work over the last few years. Very briefly, I work in lots of different places in the country, but also in other countries as well. Closer to home, West Yorkshire has done some amazing work. They've got a system-wide, region-wide program, which started in, I guess, late 2018, early 2019. They approached me and said, we need some expertise, we need some support. We've got an ambition, we've got commitment, but we need to bring all that together. So initially it was a group of 22 people, and we got into a room and we conducted a workshop using this model, the trauma system change model. And it was really about saying, okay, this is an insurmountable task on the face of it. How do you steer a whole region towards employing this science and this knowledge of trauma, stress, and adversity? And resilience, how do we bring that in a way that ties the system together, that becomes a long-term ambition that just doesn't change with the seasons? So we started using this model as a kind of framework for the workshop that we did. And at the end of that workshop, which was mixed stakeholders, different levels of seniority, and ultimately the coalition of the willing, and we got a straw man. We came away with a straw man for a strategy. And we looked at, what was currently available for people in West Yorkshire. What were the strengths? What were the gaps? What were the offers against the global evidence? So we know what works in prevention, but what's actually available currently? We looked at how we could tie the system together from a governance perspective. This could be a single integrated vision for the whole of these organizations that have very different challenges and agendas. And then we talked about commissioning and how that can drive service and cultural reform, sometimes far quicker than waiting for the government to change policies. And then we talked about how we were going to build and support and protect the workforce to do this work, and what they needed. And then we also talked about community. How are we going to do this with our communities and places? How are we going to do this in partnership, create engagement, create empowerment? How is this going to be co-produced, basically? So each table moved around these different subjects, and we were facilitated. And by the end of it, we had a bit of a plan. And then I'm going to skip 4 years, and then because we haven't got long, but over the past 4 years, we've done loads of amazing work. There's a huge group of people now, like over 500 people actively in this network across the work streams, leading the change. There's 5 places in West Yorkshire: Leeds, Bradford, Wakefield, Kirklees, Halifax. I think I could be wrong. My geography is terrible. But all the places have got their own programs that mirror the system-wide program, and we've got work streams around the training collaborative. How do we convey this knowledge? We've got a trauma of racism work stream. We've got work streams around reducing violence towards staff. We've got organizational practice work stream, digital online harms, community action collective, specific work stream around healthcare, specific work stream around education. So all these things are ongoing, and there are amazing pieces of work happening in lots of different settings. I've been involved in lots of them, but I haven't got time to tell you about each of them. But we've done really, really kind of powerful change programs in different settings, as varied as HMP Leeds, which is a remand prison, to A&E at Calderdale and Huddersfield Hospital, where youth workers are embedded in A&E, and they can stay with a young person on their journey, navigating what they need for 6 months after their attendance at A&E. And they found that it's reduced frequent attendance, and it's saved them hundreds of thousands of pounds in the last 6 months. Because young people get what they need rather than presenting repeatedly with the symptoms of their problem. Instead, they get to the root cause of the problem and give them the support they need to change things. So there's a lot of great work happening, but crucially, after 4 years, we went back to the System Leadership Executive, which is basically all the CEOs of NHS organisations, local authorities, city councils, big third sector organisations, policing. All those CEOs are on this committee, and they steer the Internet Care Board. So myself and the programme lead went back to them around 6 months ago and said, are you still on board? A lot's changed. A lot's happening in the world. We need to reaffirm your commitment to this. So we went with these 5 requests. Are you still up for everybody, all the organisations in West Yorkshire experiencing, aiming towards trauma-informed practice? Are you on board still with the idea that we need to deliver high-quality training with fidelity across the workforce, just like we do with safeguarding? Are you on board with the idea that reflective practice and restorative supervision is part of the solution if we're going to look after the workers? Are you committed to prevention? Prevention is often the first thing that goes when finances are tight, but it's part of the solution. So we really wanted to know that they were still committed to this, to make this a reality. And then finally, are you still committed to growing these local partnerships at place and making this sustainable over the long term? And the answer was yes to all of those things. The resounding yes to all of those things. So we've got the endorsement of the key leaders who can unblock things for us, all coalescing around the vision. So it's really, I wish I had more time to talk about this. Actually, it's really fabulous work, but it's possible, it's doable, and there is a bit of a recipe for doing it. And the things that I've been doing over the last 7 years since I left the NHS, whereas now basically I spent all of my time doing this work, this change work around trauma. 7 parts to the methodology, not necessarily in this order, but actually, organizations and systems sometimes go in this order, but sometimes they start with the training or something else they feel is very pressing. But the collaborative inquiry is ethnographic research or ethnography. It's basically about understanding culture and practice. So we might say, okay, we did a big piece of work with the NSPCC to help them develop their strategy around trauma-informed practice. So the questions might be, for example, what does your workforce understand about trauma-informed practice? What do you think the barriers might be? Where's the existing good practice? Um, would you feel comfortable asking your manager for help if you were stressed? Would you spot the signs of burnout? What makes you want to keep doing this job? What are the things that make you want to leave this job? What are the things that you think are most helpful to your service users? So we frame the questions. We use a method called framework method, and we frame the questions to answer our objectives. And at the end of it, after doing focus groups with staff and service users, stakeholders, and surveys, and we bring those two chunks of data together, and we produce recommendations based on what people have told us. So we end up with a plan that fits perfectly with the context that we're looking at, because the solutions have been generated by the people. And the great thing about that approach is you get a bespoke plan. But not only that, it's very hard for senior leaders to ignore this plan because, and this was an accident that we found this out, but if you take the risk of asking the workforce, for example, what do they think, what do they feel, what do they want, what do they need, and then you don't respond to it, that's a big problem. So it's a huge opportunity for moving this on, for creating momentum and buy-in, and reducing resistance. Then we obviously need to give people the knowledge. So we've been delivering foundational training across the country for the past 7 years, and we've now got a really well-developed recipe that's been really well evaluated, really well received. But we're now training other people to deliver it so that there can be a big expansion of this knowledge. And the bottom line is it has to be the same as safeguarding. If you work with people, you need to know about this. And it's not going to be something you just do once. It'll be something you have to keep your knowledge up to speed with. And it doesn't matter if you work in finance or if you work in refuse collection. You need this knowledge because you're interfacing with people. You're making decisions that affect people. You're hearing about people's lives. And you have colleagues, or you've got service users to help, or you've got family. So we want this information to be in the hands of the people who can make good decisions based on it. Routine inquiry about adversity is fundamental. If we don't ask people what happened, they tend not to tell us. I was involved in a study of 600 survivors of sexual abuse. And what we found in that study was that it was about 22 and a half years from the point the person started to experience abuse to the point where they were able to tell someone. And in that period of time, the average health costs for each person were about £5 million because they didn't get the help they needed. So we have to ask people what happened to them. I'm going to tell you a little bit more about that in a minute, but currently it's very, very few and far between where this happens. So I spend a lot of time training teams how to do this safely in a way that feels therapeutic for service users. People normally appreciate being asked. I'll move on and we'll come back to that briefly in a second. So therapeutic skills and ideas for workers with a relational role. So we think it's really important to democratize psychological science. There are so many people who work with their relationship with service users. There are so many managers supporting staff. Well, they're all looking after the people, so they've got to have some skills that are psychological. Now, most people are wearing several hats: mentor, advocate, counsellor, therapist, social worker, and that might not at all be in your job description. So, we found that if we can give people a little bit of psychological technique and some generic skills that are going to be useful in their role, they're going to be more effective. They're going to be empowered, and they're going to be able to give things to service users that maybe they couldn't before. So we're getting a really good response to that, and I feel excited about it because the more we can do to give people evidence-based techniques and ideas, the better. There's never going to be enough psychologists. That's the bottom line. We have to protect people from compassion fatigue, burnout, and secondary trauma. So we teach staff and managers about that, how to spot it, how to measure it, how to know what the early warning signs are. And we really must make reflective practice and restorative supervision part of everybody's practice. Some professions, it's kind of standard. In other professions like teaching or policing, it's just not a thing. But they've got very stressful jobs as well. So actually, this is for me one of the ways we protect the workforce. We learn, we connect, we come together, we process, we make sense of. I think it should be standard. So I'm glad to say that's becoming more and more common. And then finally, measuring the right things. If we don't measure the right things, we continue to incentivize the things that aren't going to make a difference. So what gets measured gets done in organizations. So we think about practice standards or quality standards for services or teams or organizations, and we think about measuring some things that are going to incentivize change. One of the things I really like to measure is the quality of relationships, psychological safety, um, how looked after people feel by their organization. There's lots of really useful things. Relationship quality is a real strong predictor of outcome. Maybe we could measure that more often. Just regarding briefly the routine inquiry work, um, we've been doing this for years, but the evidence, we've got 8 independent evaluations from different universities. The evidence is if you give staff some training, they tend to feel confident and they tend to start asking service users what happened to them in a consistent way. Service users tell us it's acceptable and desirable to be asked what happened to them, and people get what they need sooner if we understand what's underneath their pain. And ultimately, we can safeguard people as well, because if you ask someone what happened to them and they tell you, you can say, thank you for sharing that with me, I believe you. And is that still happening? And what kind of help do you need? Does it still affect you? But we also see service users having a motivational kind of moment. People have a kind of upticking up motivation and start to make positive life changes because they understand the source of their pain. And when we ask parents about their experiences of adversity, and we train health visitors to do this at antenatal visits, pregnant women, for example, say, thank you. That's a really important question to be asked. And actually, my childhood wasn't very good. And I really do need some support with knowing how to parent my kids, because my experience of being parented wasn't very good. So this is an opportunity in that context for primary prevention. And when you've had a conversation about people's adversity, it naturally leads to a conversation about resilience. In California, the whole state of California, if you're a pediatrician or a GP, you're being incentivized to ask about adversity. So they get paid like 30 quid or something for doing an ACE screening in the same way they would as a flu jab. But that becomes then a public health intervention because they can give people the right kind of help sooner, which is going to help them if they're an adult and their children. So they educate and support people to understand what are the antidotes to adversity. And these are all of these areas on this diagram are areas where they give people education and knowledge. They're the kind of 6 most evidence-based. No, there's 7, isn't there? Yeah. 7 most evidence-based areas in terms of coping with stress and recovery from trauma. So I think this is a great opportunity to educate people, give them skills, give them knowledge, give them coping strategies, help them adapt, and help people realize that it's not all about treatment. Some of this is about building up assets. Prevention is possible. If we have this long-term commitment across a whole area, if we have an investment in preventative interventions, if we become more trauma-informed, we might be able to reduce the incidence and the impact of adversity for future generations. Public Health Wales did this study 2013, 4,000 people. They looked at their levels of adversity and their health harming behaviors as a consequence. They calculated if they could stop adverse child experiences impacting the health of the next generation, that we would see a reduction in crack and heroin use by 60%. Half as many people being the victim of violence or the perpetrator of violence, and over half as many people, 53% of people less, going to prison. So we could see transformational change in population health if we could really get behind this and start investing in a long-term vision. World Health Organization, Centre for Disease Control, Public Health Wales, they've all done evidence reviews of the things that will prevent and mitigate adverse child experiences. These things centre around 4 areas. Number 1, preventative strategies. There are pages and pages of preventative programs. They're all in these documents. It's important to do a gap analysis against what's available in your area versus what's not. We're thinking about things like supporting child and family well-being, making sure parents have got the resources and support they need to raise their children in a safe and loving environment. Parenting programs are really important. There's a huge return on investment for parenting programs. And in some states, in some parts of the world where they experimented with making parenting programs universally available to all parents, for example, in South Carolina, they did it for 2 years and they saw a reduction in child abuse of 25% just by giving parents more skills and strategies. And then the other thing they agree on is that we have to detect and mitigate ACEs. We have to find out what's happened to people sooner, and then we have to give them the right help. That means we need to ask people in a sensitive way, offer them the right support sooner instead of just treating the symptoms. And then the final one is we have to focus on what public health would call salutogenesis. How do we keep people healthy? How do we keep people well? What do we do to promote resilience? And I think this is often an afterthought, actually. It's far better to keep people resilient and healthy than it is to try and pick up the pieces when they've become sick or they're in crisis. And this is kind of what I spend my time doing is trying to figure out strategies that can make this change possible. So I'm gonna sort of draw this to a conclusion. Maybe there'd be time for a couple of questions. I don't know because I only started my timer a few minutes after I started. So my conclusions are these, right? We need cross-sector commitment to trauma-informed and prevention-focused practice. It's got to go beyond any single leader, right? If you're sat here watching this and you're a leader, it's about the next 10 years. It's not just about your tenure, it's about the person that comes after. If you're a politician, it's not just about your term in office, it's about the long term. We've got to increase awareness of adversity, trauma, and resilience. We've got to make this mandatory knowledge. Every worker should know about it. We should make this knowledge available to parents. They put this information into the hands of the people and they will invent very wise actions. Professionals need to know how to talk to people about trauma and adversity. If we don't ask people, they tend not to tell us because there's shame, there's embarrassment, there's fear of not being believed. And if we don't ask, people keep it buried. So we have to get better at doing that. They're doing it in the state of California. They're doing it in, I think, the state of Oregon. It is possible. We got close to it in this country a couple of times, but not quite got there yet. We need to get more access to trauma-focused therapies. There is no equal choice. If you go to your GP, there is no equal choice. There's no parity of esteem between physical and mental health support. Trauma-focused therapies are essential for people who need them, and they're very cost-effective. And then finally, we have to put the workforce first. Someone said to me the other day, you always talk about the workforce first. Does that mean service users second? And I always say, well, you can fathom it or do the diagram however you want, but the bottom line is if you don't look after your workforce first, there is no service. The quality, the care that you provide for the people, caring for the people, is going to be manifest in their interactions with the people that they're trying to help. Currently, we've got a huge deficit. Everyone's working too hard. Everyone's getting exhausted. You've got to look after people so they don't want to go anywhere else. They don't want to leave the profession. They don't want to go off sick. They love what they do. They feel supported in what they do, and they can bring their empathy, their care to the people that they're supporting. And my final point is this: it's all about relationships. You can have a fabulous strategy. You can have an amazing governance system. You can have tremendous commissioning arrangements. But ultimately, it comes down to relationships. This is a relationship-driven movement. And that isn't just a platitude. The science backs it up. The Harvard study of adult development, otherwise known as the Harvard Grant Study, has gone on for almost 90 years. And they studied a whole cohort of people and their offspring. And they found that following them up through their lives, the best predictor of how long they lived and how happy they were was their quality of relationships. So if they said that they had satisfactory relationships, particularly in their 50s, they tended to live till they were 80 and be in really good shape. And that predictor of relationship quality was more powerful than diet, IQ, social class, so much money they had, their genes even. So it was incredibly powerful. Studies of post-traumatic reactions, post-traumatic stress show, there's lots of studies that show that relationship support, having supportive friends and family, is a really strong predictor of recovery. And conversely, people who don't feel that they've got good social support struggle to recover. In psychosocial interventions, the single most predictive factor of change, of positive change across psychosocial interventions over 50 years of research, and when I say psychosocial interventions, I mean counseling, psychotherapy, CBT, mentoring, whatever psychosocial intervention is, relationships the best predictor of change. If people said at the end of the study, how was the quality of the relationship with the therapist, counselor, advocate, whatever? If they said satisfactory, people tended to get better. If those people said neutral, they didn't get better. They had no benefit. And if they said the relationship was unsatisfactory, they got worse, even though they were seeing someone very qualified. So the implication is we have to look after the people that are looking after the people, because the people doing the work are doing the work through their relationship. So they've got to be in good shape. They've got to have some compassion, some empathy available in order to have that impact. So I'm going to finish on that note, that really important note. I'm going to finish with the words of Irving Yalom. He was a famous American psychotherapist. He wrote a book called Love's Executioner and Other Tales of Psychotherapy. And on page 114, he said he recounts his story of when students come to his class at the university and that they're really in awe of him because he's, really famous and he's been doing this for 50 years. And they're always asking the same question, what's the secret? What's the secret to being an amazing psychotherapist? And he'd say, well, it's a professional rosary. It's the relationship that heals, the relationship that heals, the relationship that heals.